The next speaker for today is not only online, but is a recorded lecture. So bear with us in that. So we're going to listen to Professor Fernando Scigalia. He is expert in mitochondrial disease, professor of Department of Molecular and Human Genetics in Baylor College of Medicine and Texas Children's Hospital, Houston. He is the co-director of Pediatric Mitochondrial Medicine Clinic in Texas Children's Hospital and director of the Center for Medical Genetics, Prince of Wales Hospital in Hong Kong. So we'll be looking forward to hear what Professor Fernando has to say about mitochondrial disease, current and potential future therapies for mitochondrial disease. Problem as it's possible in these things. So can I take the opportunity to invite next speaker, Dr. Vidya Narayanan. She's my colleague, consultant at Mediclinic Parkview Hospital, consultant in Pediatric Endocrine Medicine at Mediclinic Parkview Hospital. Welcome, Dr. Vidya. We're speaking on rare diabetes.
First of all, thank you to the organizers of this conference, Dr. Ayman, for inviting me, and thank you, Dr. Sunny, for that introduction. I'll be talking about rare diseases in children. So just outline of my talk, we'll discuss about types of diabetes, recognition of rare diabetes and how to manage them. So as we all know, the classification of diabetes is type 1 diabetes. So previous diabetes. Type 1 diabetes, type 2 diabetes, which is because of insulin resistance with progressive insulin secretory defect, gestational diabetes, and other specific forms of diabetes, which is what I'll be talking about today. So notably, genetic defects in beta cell function, reducing the insulin release, and genetic defects in insulin action. Next slide, please. So rare diabetes, there are different subtypes: neonatal diabetes, eventually onset of diabetes in young or MODY, genetic syndromes like Wolfram, Armstrong, Bardet-Biedl, Wolff-Olsson syndrome, thyroid-responsive megaloblastic anemia, insulin resistance due to either receptor mutation or lipodystrophy syndromes, mitochondrial diabetes, and also an entity which is early onset diabetes along with autoimmunity, which may be because of several mutations, but notable ones being AR gene mutation and FOXP3 mutation. Next. So when do you suspect that a patient may not be having type 1 diabetes? So onset of diabetes at age less than 6 months, or onset between 6 to 12 months, but without any autoimmunity. If there is family history of diabetes in one affected parent and first degree relatives of the same parent, if there are absent islet cell autoantibodies, especially at diagnosis, because later on, a few years after diagnosis, the antibody levels can go low. If the patient is still on a very low dose of insulin with detectable C-peptide levels a few years after diagnosis, if there is no ketonuria noted during any illness, and if there are other associated anomalies. And when to suspect that you may not be dealing with a type 2 diabetes. So if the patient is not obese, especially less than 45 years of age, if there are no markers of insulin resistance like acanthosis or any metabolic syndrome associated, and also if there is any pattern of unusual fat distribution which may suggest lipodystrophy. So there are several genetic mutations which are implicated in monogenic diabetes or neonatal or early onset diabetes, but I'm not going into the details. So coming to maturity onset diabetes, or MODI as we know it, this is monogenic diabetes because of single gene mutation with a prevalence of 1 in 10,000 in adults, usually characterized by early age onset. So typically less than 35 years, and if the age of onset is less than 25 years, that's especially important. If there is a family history suggestive of autosomal dominant inheritance, and as mentioned earlier, any absent autoimmunity or persistent insulin secretion, absence of obesity, and markers of insulin resistance. There may also be specific features like glucokinase MODI can just present with mild, non-progressive fasting hyperglycemia. HNF1 alpha mutations may have glycosuria. HNF1 beta mutations may have renal or genital malformations. And HNF4 alpha mutations may be associated with neonatal hypoglycemia and later on macrosomia and later on Fanconi syndrome. So coming to each individual subtype, glucokinase MODI, this is a heterozygous or autosomal dominant mutation. It's a commonest subtype, and usually these come to light when you do blood tests and find incidental hyperglycemia. These patients are usually asymptomatic. So they have a high fasting glucose, but when you do a glucose tolerance test, there is not much of an increment with the glucose load. These patients have a mild increase in HbA1c, but usually less than 7.5%. The prognosis is good, so macro and microvascular complications are rare, so you don't need to treat these patients. Sometimes some of these patients may be diagnosed in pregnancy, and they may need treatment in pregnancy because of fetal macrosomia and fetal risk. So this particular study looked at mean HbA1c of patients who were treated with oral hypoglycemics or with insulin, and basically there was no difference in HbA1c whether you treat them with insulin or with oral agents, so no point in treating them. HNF1 alpha mutation, this is the cause of commonest monogenic diabetes in symptomatic familial diabetes. Usually presents a bit later compared to the glucokinase MODI. Fasting glucose may or may not be normal, but usually the increment on GPD is much more than 5 millimoles per liter. Ketosis is rare, and this subtype has renal glycosuria, and risk of microvascular complications is similar to type 1 or type 2 diabetes. And they are very sensitive to sulfonylurea. And in this particular study, they looked at response to sulfonylurea and metformin in type 2 diabetes versus HNF1 alpha mutation. The darker column being the HNF1 alpha diabetes, and you can see the response to sulfonylurea glycoside was much more in these patients compared to patients with type 2 diabetes. So coming to the treatment of each subtype, so glucokinase MODI, no treatment is needed. HNF1 alpha and 4 alpha you can treat with sulfonylurea. 1 beta often require insulin, and other types like KCNJ11 and ABCC8 mutation, they need high dose sulfonylurea. There are several other subtypes, but I haven't gone to the details of all of them. Now, coming to other genetic diabetes, Wolfram syndrome, which you might have heard of, this is autosomal recessive. There are two subtypes. There is Wolfram syndrome type 1 and type 2. And the characteristic feature in these patients is a non-autoimmune but insulin-dependent diabetes. And they also have optic atrophy. And many of these patients have sensorineural hearing loss. And in subtype 2, you also have peptic ulcers and bleeding tendency. Diabetes usually presents very early in these patients, but the risk of complications and diabetic ketoacidosis are less. So there is a mutation on the WFS1 gene, and this gene normally codes for wolframin, which is a transmembrane protein in the endoplasmic reticulum, and this is important for the endoplasmic reticulum stress response. So if there is mutation in WFS1, this causes ER stress response, and there is accumulation of insulin precursors which cause cell death and insulin deficiency. And WS2 is because of mutations in CISD2 gene, which again is involved in endoplasmic reticulum stress response. So if you have a WFS1 mutation and wolframin deficiency, there is increased levels of the ATF6, which causes prolonged unfolded protein response activation in an endoplasmic reticulum, causing cell apoptosis and cell death. So to diagnose Wolfram syndrome, you have major symptoms as well as other common symptoms. And so among the major symptoms, the most important, as I said, is diabetes as well as optic nerve atrophy. You can also have neuropsychiatric symptoms, autonomic symptoms, and endocrine manifestations like hypogonadism. So comparing type 1 and type 2, so diabetes, the ocular features, deafness are common to all. The endocrine manifestations and neuropsychiatric manifestations are usually not seen in type 2, and in addition they have genitourinary, in addition they have GI ulcers and platelet aggregation defects. So looking at the natural history, as you can see here, diabetes mellitus and optic atrophy present quite early, and the neurological manifestations appear in the 3rd or the 4th decade. So the diabetes in these patients is easier to manage. They require much lower doses of insulin, and they usually run a lower HbA1c. However, these patients may have hypoglycemia unawareness because of the neurological dysfunction. At present, there are no available treatments which will reverse the progression of the condition, though there are several trials going on with genetic treatment. Careful monitoring and supportive care can help to improve the quality of life. However, death occurs at the mean age of 30 years because of respiratory failure due to bulbar dysfunction. Bardet-Biedl syndrome is quite rare, has variable inheritance with recessive and multigenic inheritance. It's one of the celiac conditions, and I'll talk about another one aspect called Alström syndrome. And here you may have mutations in any of the 22 genes which encode the BB somes. And the cilia are important in the pathways which regulate cell division, polarity, and metabolism. And here you can see section of the primary cilia. Okay, so at the base of the cilia, you can see in red the BB-some complex, and next to it in yellow is the chaperone complex, which are important in regulating the transport through the cilia. So there are several features which help in making a diagnosis. So primary features as well as secondary features. To make a diagnosis, you need to have 4 of the primary features or 2 primary features along with the 3 secondary features. And the typical ones are the road cone dystrophy, post-axial polydactyly, truncal obesity, learning difficulties, and hypogonadism. As you can see, it's the same person who is quite obese having polydactyly, micropenis, and dental crowding. So the obesity is quite early onset in these patients at 2 to 3 years. Retinal degeneration happens at the age of around 8 years, so they are diagnosed usually by 8 to 9 years. Obesity is seen in most of them, and with a BMI of about 35, so quite morbidly obese. And diabetes and insulin resistance occurs in around 40%. And the risk of diabetes increases with age, and also there is a high incidence of metabolic syndrome in these patients. So recently there has been a trial of setmelanotide, which is a melanocortin 4 receptor agonist in patients with Bardet-Biedl as well as Alström syndrome. So this was a randomized controlled trial comparing setmelanotide to a placebo, and they recruited 16 patients of Bardet-Biedl and 3 patients of Alström syndrome in each arm. This was not very effective in Alström syndrome, but in patients with Bardet-Biedl, there was significant weight reduction of 32%. In 32% patients who had at least 10% weight loss, and they were treated over a period of 1 year. And the side effects were minimal. So these patients, not just Bardet-Biedl syndrome, all the other syndromes like Alström syndrome, Wolfram syndrome, they all need multidisciplinary input with periodic monitoring of their periodic ophthalmology assessment of the hearing, genetic review, dietetic review, learning support, etc. And Alström syndrome is an autosomal recessive condition which is quite rare, has a prevalence of less than 1 in a million, and these usually can present with congestive heart failure in the first few weeks of life, which may then improve and then present again with cardiac failure much later in life. They have rod cone dystrophy, so causing nystagmus and retinopathy, sensory neurohearing loss, childhood obesity, hepatic steatosis, and severe insulin-resistant progressive diabetes with hypertriglyceridemia. They can also be short and have hypothyroidism and gonadal dysfunction. So in this slide you can see the age of presentation. So at birth to the first few months they can have ocular manifestations, and later on in life, hearing, liver failure, diabetes, renal failure, all these happen. So management from an endocrine point of view, monitor plasma insulin yearly, and if they are noted to be hyperinsulinemic, then do fasting blood glucose. Lifestyle intervention, and initially oral agents may be effective, but later on they will need insulin, and these patients have a reduced life expectancy and a median age of death around 30 years, usually again from bulbar dysfunction. So there are, because these both are ciliopathies, the Alström and Bardet-Biedl, there are several common features which include the visual impairment, hearing loss, obesity, and diabetes. However, patients with Alström syndrome, they do not have polydactyly, hypogonadism, or cognitive impairment. And the one is Wolff-Rayet syndrome, which is very rare autosomal recessive mutation of EIF2AK3 gene, and this encodes for a protein which is important in regulating ER stress response. So there is misfolding of the ER proteins, and this causes stress and beta cell apoptosis. So these patients also have very early onset diabetes and spondyloepiphyseal dysplasia, recurrent hepatic or renal dysfunction. Diabetes presents quite early, and this diagnosis should be considered in patients who have permanent neonatal diabetes, especially if they come from a highly inbred population with consanguinity. So as you can see, this patient with Wolff-Rayet syndrome is quite short, having short trunk and has genu-wall gum, and in the growth chart you can see it's much below the bottommost centile. There is dysgenesis of the carpal bones as well as epiphysis. I don't think it's projecting well, but the vertebrae are quite flat and abnormal looking anteriorly. And in the hip, you can see the acetabulum is quite flat, and the upper end of femur epiphysis also is abnormal. Mitochondrial diabetes, I think we have a talk on mitochondrial disorders, so I'll probably not go much into the details. But if you have familial diabetes with maternal inheritance, multi-organ involvement, then consider this diagnosis. Usually the onset is insidious, but it can present with diabetic ketoacidosis in around 20%. Patients have sensory neural hearing loss, which is more severe in males, and have external ophthalmoplegia and other ocular features. So the females transmit the mutation to all offsprings, but because of heteroplasmy, wherein some cells or some tissues can have both mutated and normal DNA, it may not be manifested in all the patients. And diagnosis is by genetic testing in the blood, and if that's negative, then test the urinary cells or skeletal muscles. So these patients respond to oral agents, but bear in mind that metformin is contraindicated because of risk of lactic acidosis. They progress very quickly to needing insulin, and usually you can differentiate from OD because by the maternal inheritance, maternal transmission, sensory neural hearing loss, and multi-organ involvement, and you need to screen all the family members who may carry the mutation for the other associated features. Something called thiamine-responsive megaloblastic anemia, which usually presents, as the name implies, with megaloblastic anemia, and you have ring sideroblast and peripheral smear. It affects all three cell lines in the bone marrow, and usually the treatment is with insulin but low dose. And they respond to thiamine, but with time the condition can progress despite the initial response. So also insulin resistant syndromes that I mentioned, where there is a receptor mutation. So here, as you can see, there is a spectrum of Donahue syndrome and Rabson-Mendenhall, where the deficiency is most severe, and type A insulin resistance, where the deficiency is not so severe. So type A insulin resistance usually presents in females with severe acanthosis, irregular menstruation, and hyperandrogenism, and is usually treated initially with insulin sensitizers but may need insulin, and they may improve with recombinant IGF-1. The other two syndromes that I mentioned, the Rabson-Mendenhall and the Donahue syndrome, this is more severe end of the spectrum, autosomal recessive conditions, where you have, in Donahue syndrome, they have severe growth retardation and severely hyperinsulinemic, impaired glucose tolerance, and diabetes, and they die quite early. Rabson-Mendenhall usually presents a bit later compared to the Donahue syndrome, again have severe insulin resistance and severe diabetes and poor prognosis, microvascular disease, and diabetic ketoacidosis, usually die in the second or third decade. There's also lipodystrophic syndromes, which may be complete or partial. So these patients have severe insulin resistance, severe hyperlipidemia, fatty liver, and these two mutations, the ACPAD2 and BSCL mutation, are seen in the complete or congenital generalized lipodystrophy, of which the BSCL mutation is more severe. So you can see there is lipoatrophy in certain areas and hypertrophy in other areas. And there are partial congenital forms because of mutations in the LMNA or PPARG gene mutation, where the diabetes appears a bit later compared to the complete forms. So the treatment initially, you can try insulin sensitizers like metformin or glitazones. And recently, for the severe congenital forms, recombinant leptin has been tried with some effect. So why does a correct diagnosis matter? Because it helps to predict the course of the disease, helps to identify and manage other associated features, and you can decide on the most appropriate treatment for the patient, and helps to diagnose other family members and offer them early treatment as well, and give genetic counseling. So to summarize, identifying monogenic diabetes in children and adolescents is challenging. You should identify the cases, and genetic testing should be performed in appropriate ones. And when you don't have typical classic features of type 1 or type 2 diabetes, especially if they are early onset, there is a very strong autosomal dominant family history or other features, then consider genetic testing. Because early diagnosis may improve the prognosis and disease management and improve the quality of life.
least more than 20 genes that can cause BBS, for example. And in a small database in a tertiary eye care center in Saudi Arabia, we actually identified at least 40 nuclear families. And I do recall also that I had a family with Alström syndrome. Out of actually 10 children, 5 of them were affected. So it's not that uncommon. This highlights also the need for multidisciplinary team management of those patients, because sometimes the first presentation of those patients will be a severe retinopathy, and then the family isn't really that concerned about, the obesity and the other manifestations and the learning disability. They think it's part and parcel of the loss of vision. And unless actually good screening program and a multidisciplinary clinic actually dedicated for those patients is established, where those patients can be seen regularly, like the example in Guys and St. Thomas in London, for example, Professor Phil Beals has built a complex multidisciplinary clinic for those patients to be thoroughly evaluated and managed properly. I think those patients are underserved because they are seen by different specialties and sometimes the family gets lost in between. That's one aspect. The other aspect is that patients also with Alström syndrome, they do have intellectual disability. There are quite a few of them who are, even they start, learning braille, for example, and they struggle because of also behavioral problems. The third thing is that probably, I don't know whether diabetes is prevalent in patients with Cohen syndrome due to mutations in BTS13B Cohen syndrome. They do have a BBS-like body habitus, and they are often misdiagnosed as BBS until genetic diagnosis is actually confirmed. And they do have more or less the same intellectual disability level, the same retinitis pigmentosa phenotype, but they don't have polydactyly, and they do have very curious, actually thin, tapered fingers. And when they present, sometimes you can elicit history of frequent febrile illnesses during childhood, which is the family might have overlooked. And those patients actually can have, low WBC counts from time to time, and that can cause actually slightly abnormal immune response to infection. All of these things are being, underrepresented because we rely on the Western data and we don't look at our own prevalences. So thank you very much.
Yeah, I agree with you, and thank you very much for your insight. So, to be honest, the cases of rare diabetes that I've seen were mostly involving a children's hospital where I trained with Prof. Tim Barrett, and we used to have a multidisciplinary clinic, so separate clinic for Alström syndrome, Wolfram, Bardet-Biedl, and it was like a one-stop clinic. So they would come in, they would see all the therapies, the dietitian. So I agree that is the way forward, but it is challenging here, where much of the practice is in the private sector. And I don't think I have any cases of rare diabetes at present. It's almost type 1 or type 2.
So I just wanted to ask you a question, because some of our patients with BBS who are super motivated to lose weight even undergo bariatric surgery before they even get diagnosed with BBS in the first instance. And actually, the ones who are motivated and they control their diet, they maintain the weight loss after bariatric surgery. What's your experience with that?
The weight management in these patients is very challenging. I think, as I pointed out, there is the trial of setmelanotide, which just had the phase 3 study, which seems to be effective. But the treatment period was over 1 year. How long it can be given safely, whether the initial weight loss that was seen can be sustained, I'm not sure. Again, whether I personally haven't seen any of those patients have undergo bariatric surgery, because obviously my background is pediatric and adolescents, and they don't fit the criteria for bariatric surgery age-wise. So my experience with bariatric surgery in these patients is actually none. But yeah, they are usually managed in the multidisciplinary clinic with dietitian and weight management, with some effect. But I think setmelanotide could be effective in these patients and could be offered.
Any more questions? Time for one more question. Thank you. Just giving a question of mine in terms of course, we both
coverage, that that's going to be very challenging. In the setup in Mediclinic Parkview, we do trials, so I have the diabetes educator join me. She tries to come in, but again, it's like dietitian is sat in another corner in her room, I'm in my room. So I think at present with the way it works with the insurance, it is challenging. Unless maybe it's possible in